right, it looks like we're up to about our usual live attendance numbers. So it's my pleasure to introduce Dr. Mark Pittlekow. He is the professor and chair of dermatology at Mayo Clinic in Arizona. He is the named professor, the Robert S. Tots Professor of Dermatology. He is also professor of biochemistry and molecular biology in the graduate school. Dr. Pittlekow graduated followed by a residency in dermatology at Mayo Clinic in Rochester, Minnesota, including a research fellowship in experimental pathology. He is now the professor and chair at Mayo Clinic since August of 2013, and he was formerly a professor and consultant of dermatology at Mayo Clinic in Rochester. Dr. Pittlekow is the director and chair of research for over 20 years, and he has been co-chair of the melanoma study group since 1999. His current areas of profiling and growth factor expression and function in the epidermis and skin. He has also focused his research on translational dermatology and understanding the mechanisms underlying a variety of skin diseases, including paraneoplastic syndromes, which he will discuss today. And the title of his talk is Paraneoplastic Syndromes, Past, Present, and Divining the Future. So Dr. Pittlekow,
wonderful.
If you're able to share your screen.
If we can get the Do you see that one?
Thank you.
Yeah, wonderful. So thank you for the nice introduction, and it's really a pleasure, as I was just talking with Bill this morning, really to be part of this and realize how this has all become part of our really daily education. And it's a pleasure really to talk about a subject that's been recollections of some of the most challenging things that we see in dermatology, and that is these paraneoplastic syndromes. So I'll give you a little history. Really, the fact is that some of the earliest stemmed from understanding what we saw, and that was with the skin at the time, and then subsequently where we are now. And then I'll try to see what we can do about predicting or divining, if you will, the future. Advance here. So no disclosures, and we will be discussing some off-label therapies. So really, although here we are in the 21st century, it was really in the 19th century, late 19th century, when the first account of it I'll give you. It's really quite remarkable, because as we look at skin every day and we recognize what are the obvious, where we can make a real immediate diagnosis and therapeutic recommendations. Other times, for paraneoplastic syndromes, they're really quite obscure and take extensive patient bearing the burden of the disease before we can really understand what's going on and offer the best treatments. And lastly, these challenges of really understanding what the mechanisms are, which is probably the holy grail of much of what we see, everything from now immunotherapy, immune checkpoint inhibitor treatments that some patients tolerate very well, and some people therapy because of the seriousness of the side effects of the disease, often, of course, that are autoimmune, but directed, of course, at the tumor. And that was the intent, but with, unfortunately, some of the collateral effects. So just a definition of paraneoplastic syndrome. Obviously, there it is. This was Stedman, hormonal neurologic, hematologic, other clinical and biochemical disturbances associated with malignant. I would qualify that, we'll talk about that, but not directly related to invasion by the primary tumor, its metastasis. So first is neoplasia is not malignancy. And unfortunately, when they say malignancy, in fact, sometimes we see neoplasia or paraneoplastic reactions that fortunately are not frank malignancy and often may have a very good outcome. look at hormonal, neurologic, hematologic. Well, what's missing is that, they don't have dermatology. And here's Dorland's definition: primary endocrine, hematologic, or neuromuscular disorders, but cutaneous manifestations are missing. So I would even take you back to the simplest thing, a definition that is lacking. So what's the fascinating medical students who may or may not know this, but or if you've ever seen Trousseau sign or syndrome, but Armand Trousseau was a famous physician and surgeon, born in Tours in France, and then really most of his career in Paris. And in 1865, he described migratory thrombophlebitis, or that famous old term, Phlegmasia albidolens, because it changes and all. And he noted the association with secreting adenocarcinomas, but it's also been seen in gynecologic lymphoma, brain, etc. And in fact, at least 50% are associated with malignancy. How this occurs, we don't really understand, but there's probably hypercoagulable or other associated with the malignancy. But the ironic aspect about this is he diagnosed his own occult gastric cancer on New Year's Eve of 1867. And I would recommend a nice old article now in 1967 in the French literature by Souberan, who basically translated. He says, "I'm lost. The phlegmasia that showed itself last night leaves no doubt." And then I move forward about 60, 80 years to Jan Waldenstrom. And obviously, we all know Waldenstrom for his Waldenstrom's macroglobulinemia, but he was a remarkable internist, born in Stockholm, really is all his career in Malmö. But his range of everything from paraproteins to porphyrias, carcinoid syndrome, etc., and likely a very well-attuned clinician to understand paraneoplastic syndromes, arguably. And he really discriminated between the monoclonal and polyclonal gammopathies. But in his later career, got fascinated with paraneoplasia, and this famous book of his is a biologic signal. This was published in the 70s, and notice here, first his prelude there. Experiences from a lifetime in clinical medicine and in biochemical research to combine bench and bedside. What could be better stated than that when we talk about translation? But notice he recognized the value of skin, because in his first chapter, part one, the first one was, and why it should be actually, because as we recognize, one of the most characteristic, a variety of causes, but certainly the malignancy associated one of acanthosis nigricans, Politzer and Janowski in 1890, and then of course Derrier's description in 1893. But as you recognize, communication and looking at all the literature at that time and who first described it, sometimes varied. Schwartz and Burgess in 1978 that said, this type that occurs particularly around the orofacial areas and everything, and we sort of said, well, that's just acanthosis nigricans, but of those areas. But they discriminated, and in fact, Politzer and Una, the great German dermatologist, in 1891 described florid cutaneous papilla. subsequently designated dermatosis or sweet syndrome, as we now know it, and this association with hematologic disorders and pre-neoplastic and more recent times, 1990 first described paraneoplastic pemphigus, and then with my colleague Sergey Grando, UC California, UC initially Davison, now Irvine, characterized paraneoplastic pemphigus, but in the broader designation as we recognize it to be a term we called paraneoplastic autoimmune multi-organ syndrome, or PAMS. And we'll go into that later, but trying to not necessarily redefine, but understand the full, a little narrow in terms of the terminology we use, much like the old terminology, just acanthosis nigricans, to really capture florid cutaneous papillomatosis, where they're probably clearly different diseases as you recognize their presentations. And another pioneer in the field, Helene Kurth. She was born in Breslau, and all her career at Columbia, and a remarkable woman. And here she is with her husband, Willie Kurth, both who were dermatologists. And she recognized these benign versus malignant forms and a variety of other cutaneous signs of cancer. So her perceptions were right on, and that's why she was able to define paraneoplastic syndrome so well. I would again commend for your reading Willy Bergdorf's and Schultz's nice review and reminiscences about her and JAD in 2004. But here's her postulates, which she advanced in Cancer in 1962 and then subsequently updated in 1976 in International Journal of Dermatology. And Dr. Thier's and the Cancer Journal for Clinicians reiterated these. So these were the postulates, much like Koch's postulates. Malignancy and the syndrome must appear at the same time, and their clinical course should not significantly different. Remote cutaneous manifestation should be specific to the tumor causing them, but we recognize that sometimes that's not so characteristic when we understand the range of other malignancies beyond the classic malignancy to the prevalence of cancer, and that it should also be that they are demonstrably associated. And that's sometimes a challenge as well, but we can talk about that. And most interesting, but it's not been well proven yet, but certainly as we understand, for example, just immunogenetics, that genetic association between the malignancy and the specific cutaneous disease. But I would argue that these two of her postulates for diagnosing a paraneoplastic syndrome. So a search I did last night, you can see that relatively in terms of the breadth of what's in PubMed now, if you just type in paraneoplastic, you only get 15,000 references. And then if you look at it really with the syndrome as such, only 2,700, of which, when you bring in skin, neurologic, endocrine, you can see the numbers there. But we'll try to focus most of the time here on skin, although I must say what I've understood about skin has really been greatly benefited by what you understand about certainly blood and neurologic and all the other organ systems. So lest you think that this is something that's heaped in mystique, that's not the case, because this was actually a very nice website, the International Paraneoplastic Association, and for their support group. And it was actually developed by a patient that had paraneoplastic neurologic disorder. And some of these, as you know, can really be very incapacitating. And unfortunately, in times, plastic syndromes. Well, certainly by organ system, and that's what I've tried to cover already, but we'll hope to at least give you a little perspective on maybe, really what's the mechanism or mediating factors. And then even among the skin, you could just sort of lump them all together or alphabetically or something. But again, when we understand what are psoriasiform lesions or pityriasis rubra-pilaris-like eruptions, they look very much like psoriasis or PRP, but in fact have enough distinction to say this is not typical psoriasis or PRP. Similarly, you can see this for a lot of the erythemas and a lot of the vascular lesions, much like, Trousseau's sign. And then we'll talk about some of the other interesting disorders that, as you catalog all these, they're, from the relatively rare. We unfortunately don't have really good incidence or prevalence for some of these conditions because of their relative rarity and how you would rank order these for different populations, in fact, because some populations, racial populations may have racial ethnic populations significantly different. But what are the real big challenges? Well, first, detecting the subtle early manifestations. The earlier, and we'll talk about this at the end, but the earlier you can detect the disease, arguably, the better. Certainly the links to understanding, what is going on and why. Certain selective diagnostic tools, and there's been evolution of this in the past 15 to 20 years. And then certainly trying to manage the cutaneous manifestations, which we recognize to be, it's sort of right up front and center for us as we deal with all the patients that we have to manage with it, and certainly trying to eliminate the primary neoplastic cause. So I would argue that probably, although, if you look at the recent literature, and I keep on updating this, but maybe hematologic and neurologic are a little more common if you just look at the number of references, just because the understanding, particularly in the hematologic field and neurologic field, is, I think, gaining. But they're certainly more common in a lot of the endocrine and musculoskeletal and other organ systems. And the interesting thing is that some will target only the skin or only the neurologic system, but then of course some that we have with these overlapping, like neurosuites and things like this, rare, but these are the overlap type conditions. And then understanding the mechanism, which is arguably the most fascinating, and then to provide the effective treatment, and certainly with immune checkpoint inhibitor, the immunotherapies now for cancer, we're, I think, making great inroads with that. So as one example, just with papillosquamous conditions, a nice review for medical students in e-medicine, if you want to look up paraneoplastic syndromes. This is just how they were cataloged. So if you look at papillosquamous conditions, and this goes for all the other subtypes, you have 9 or 10, everything from acanthus nigricans to acquired ichthyosis, Bayes-X, the florid cutaneous papillomatosis, the palmoplantar keratodermas, the rare pityriasis rotunda, the laser Trela sign, tripe palms, or the acanthus palmaris, and of course even things such as extramammary pages. So I always like this old, probably anglicized, not quite right, but that which is before you and your eye can see, which is in fact what we have really the advantage of as dermatologists, and the power of careful, critical, and astute observation, which you just have to say, how is this different than what I see as a classic presentation for a disease, which sometimes, of course, happens, and yet it's not paraneoplastic. And then how do you have to weigh those, of course? And then, of course, your talents and curiosity, which I've always felt really helps to drive you forward in your career. And then sometimes just taking a step back and trying to understand what is it that makes you feel that this is not just the typical case, or not responding the way it should, or worsening despite, So this was early in my time, and Darrell Ellis was the first author on this in a journal case report. Probably extraordinary case report, in fact, with Dr. King, Lloyd, and some of the other colleagues at Vanderbilt at the time. This was a 54-year-old gentleman, sudden onset, 3 months of multiple seborrheic keratosis. And then when he presented, he actually had acanthosis nigricans and multiple things going on the epidermis at the time. And clearly with the skin exam, the irregular dark brown lesion in the left lower back, which was biopsied and found to be superficial spreading melanoma. So all that, and you say, well, there's the early, pardon me, there's the early, yeah, okay. There's the early, uh, what was all going on here. They tried to look at everything else for causes. And fortunately, because they were at Vanderbilt with Stan Cohen, who won the Nobel Prize for the EGF and all the EGF-like ligands, and his research, they did immunochemistry of skin specimens and several urine collections, which was really demonstrate what was going on. And basically, after wide excision, local excision melanoma, 5 months later, marked improvement of the acanthosis nigricans, seborrheic keratosis, and the skin tags arguably maybe a little better. But you can see here, all this acanthosis nigricans is cleared. The skin tags maybe not so much. But here you can see Western blot for the urine the 6 kD band pre-surgery. 2 weeks after surgery, it's imperceptible. So this tumor was clearly, and they demonstrated this, rare occurrence, but this tumor was clearly secreting large levels of transforming growth factor alpha, which in fact, we were the first to describe it also being an autocrine growth factor, a paracrine growth factor expressed by normal keratinocytes. And the tumor was pouring out TGF alpha, rare but remarkable. So what's new? Well, we'll talk about the last part of the presentation here about some of the new rediscovered, and it was nice that Dr. Misha Rosenbach talked previous presentation on the granulomas disorders. Pardon me. New approaches and diagnostic algorithms to identify the underlying neoplasia, and some new mechanisms that potentially are understanding not only how we can learn more about these disorders, but potentially for therapy targeting them. Bott and Steinman and the factors, growth factors, other cytokines, potentially, certainly all the interleukins and a variety of other mediators. Toxic, what are the mechanisms? We certainly understand now, as we're understanding apoptosis, necroptosis, et cetera, there may be mechanisms that the tumor is actually targeting an organ, and not necessarily through trophic factors nor immunologic factors. But the largest category, and I think immunotherapy for cancer, is the role that very cell-mediated innate or adaptive immunity plays a role. And this nicely outlines that, of course, with targeting this review, mainly the neurologic system. So where are we? Well, Mayo, at least Mayo down in Arizona, with the institute, the Biodesign Institute there, and here's personalized that of we'll talk about NAPA, which is a specific technology, and you look at various components of that, and there's a strong focus there. But you look at various other uh, uh, you know, approach what and number of malignancies that they're have, like, for example, like Pohm syndrome. you know, you could say, well, okay, that's not a malignancy, but you clearly know that it's malignancy associated. So, some of these, it's where you put them. It's the obvious malignancy directly, or the paraneoplastic response. So this is one of their platform technologies that they've developed, and it's basically a programmable protein array, or NAPA. So they take these DNA arrays and they're printed out, and then by an in situ process, you can actually translate these to various proteins and epitopes that actually will have relevance with screening to a patient's serum that may be targeting these. And so, and you'll see that little circle there, hopefully, area are recognized specific epitopes. And if these are tissue specific epitopes, then of course you can hopefully identify this. So this was the technology they use, where you can print out from this slide the genes and then express them, and then you actually have the proteins target, or any of the other precursors. And this actually has been used with the group there, Johnson and Safford, along with subsequently have been utilizing this in a broader range, and we'll talk about that, but using as sort of so-called immunosignatures for diagnosis of cancer. That was a preliminary report now, 7 or so years ago. So let me focus a little bit on blistering disease, particularly PNP, because of its interest, and as many of you know, this originally in 1990. And then with Dr. Grando, myself, and colleagues, we enlarged this to really sort of the concept of PAMs, and we'll talk about that. Why is because clearly there are the paraneoplastic, or the true paraneoplastic pemphigus ones, where you see blistering and it's pemphigus, but there's more. But then when you start seeing some that have, pathologies largely. And then, and as Dr. Anholtz noted too, I mean, and as he recognized with his experience, that some of these were not behaving as typical paraneoplastic pemphigus. So, but they were in the scope, the broad scope of what is designated PAMS, but sometimes PNP rolls off the tongue a little better. But the strong association with, Castleman's lymphoma, CLL, and thymoma. They're certainly challenging, both diagnostically and therapeutically, and they, pose, treatments, and certainly, targeted treatments, Rituxan, etc. But if you're going to be using potentially an immunotherapy for a disease, you may in fact worsen the paraneoplastic response to improve the case, with the mucosal involvement and periocular involvement. And you can see this, this polymorphic appearance, everything from, what looked like early lichenoid type lesions to just frank blisters without much inflammatory change. And then, of course, this is one pattern where you, have both base membrane. Back in 2014, with colleagues up in Rochester at that time, Julia Lehman and her husband, who happens to be a radiologist. So that was a convenient partnership there for this study. But we examined not only what our experience of about 100 cases over the years with PAMS, PNP, and then those in the literature, at that time, of course, CT was more than PET CT, and so you could see the percentages there. But what was fascinating is that look, when you really looked at the yield, PET CT actually did better, and then the fact is you could actually facilitate staging better and also biopsies, particularly with lymphomas. And since a lot of P&P PAMs were these proliferative disorders, Castman and lymphomas, we also often found that to be of benefit when you were doing PET CT. And then, of course, the value still of just immunodiagnosis with IIF, rat bladder, and ELISA, and even other more potentially to target why, for example, some have much more of a lichenoid reaction. Is that truly much humoral mediated response that we would see with the pemphigus autoimmune blistering component of the disease? So we'll switch a bit here to granulomatous, which only more recently has become fascinating to me, as it has to Dr. Rosenbach too, and his nice presentation. But classically, it was everything from Langhans cell to more Touton and a lot of generalized histiocytic cells. Here was another case that I had seen with Dr. Jasic, one of the one of the residents at the time, and subsequently that led us with Dr. Mangold here to collect our experiences, which we reported in 2018 in JAD, of a series of these granulomatous GA-like presentations. This was a gentleman who had B-cell CLL for 5 years and was doing pretty well until they treated him with fludarabine and got a remission with his CLL, but then he started developing more of a acquired hypogammaglobulinemia, required IVIG, and then he started developing all of these lesions. So it's not clear whether it was partly with his acquired CVID type presentation, or it was really partly that and the CLL that was driving this. But he started having extensive granulomatous, widespread lesions, and some that were caseating, and frankly, and that was like, oh my gosh, is this an infection? But no infection was ever identified. And subsequently with infliximab, he cleared. And then on top of that, he developed only cutaneous CLL. He was doing fine in the blood, and we actually cleared that with PUVA, believe it or not. And he continued to manage well. So here's his improvement, but these are the typical granulomas that he presented with. So here's another these remarkable cases that you have the ability and really privilege to share with your colleagues. One of my colleagues up in Rochester, retinal ophthalmologist, sent this gentleman to me, this woman, pardon me, and she actually he looked at her fundi and said, she's got B-dump. And I said, well, what's B-dump? And it's bilateral diffuse uveal melanocytosis. So proliferation, all the uveal melanocytic melanocytes, and this is uniformly malignancy related. And he said, no, this is malignancy related. Well, she had a uterine carcinoma. So we said, oh, okay, well, uterine carcinoma, but she's had that for a while, and only more recently this. So fortunately, we were able to do plasmapheresis and try to retrieve the factors, and I'll talk to you about that more. But here's some nice reviews in American Journal of Ophthalmology if you're interested in B-dump. But here was the interesting thing. So I saw this woman and I said, well, how long have you had that lesion on your dorsum of your hand? Here's a little dorsal vein. And there was this lesion. She said, oh, I don't know, maybe 5-6 months. Well, here was the biopsy. And at the time, Dr. Tom Float, who's really, one of the world experts on melanocytic atypical lesions and defined MELTUMP. He said, well, this is MELTUMP. And I said, well, what's going on here? Well, as I said, we were able to do the plasmapheresis, and we actually took melanocytes and then did the proliferation with just dilutions from normal plasma you see in the red bars, or from the B-dump plasma of this woman. And you can see difference. Now, unfortunately, we didn't do a whole statistical analysis with a lot of normal sera, but when you dilute it out, it still is persistent. So there is some trophic factor or proliferative factor that clearly is stimulating melanocytes, whether it was, derived from this primary lesion or a response to it. But and we don't recognize whether it's a trophic factor, just like TGF alpha, which isn't highly proliferative. I mean, compared to the FGFs for melanocytes, but some factor that is likely really causing this paraneoplastic reaction with this, what was called B dump. So where are we with, trying to understand things with better ways and earlier ways to diagnose underlying neoplasia? See, well, of course, has really over the past several decades, since obviously it was CT and more recently MRI, PET MRI, PET CT, to really improve that. And that was a review that was in JNCN several back in 2009. But here, 84-year-old gentleman, I saw 2-year history of pruritus and urticaria eruption. He was miserable. He had extensive previous evaluations up in Minnesota Regional VA and nothing found. But he had this terrible eosinophilia, and 1,000, 2,000 absolute counts, and this interesting eosinophilic dermatitis, which was very urticarial and miserable. His ANA was positive anti-double-stranded, but you couldn't make the diagnosis of lupus otherwise. And then even as he progressed, he even had one biopsy that showed leukocytic classic vasculitis with pronounced number of eosinophils. So it was going beyond just eosinophilic dermatitis to this eosinophilic leukocytic classic vasculitis. Well, here we did the PET CT scan, and I wouldn't have done this because he told me that in fact he had a colonoscopy. Now, I didn't go back to the VA records to document that, but this is not normally the way you do get a diagnosis of this. But in fact, diffuse FDG uptake in the prostate and focal tracer within the colon at the hepatic flexure can be seen with non-malignant, but malignancy cannot be completely excluded. Well, I sent him to the colorectal surgeon. They said, well, it's got to come out. And sure enough, it was just a tubular, high grade, but tubulovillous adenoma. And no small one, 8 centimeter by 4 by 2.4 centimeters. So it wasn't obstructing, but, much larger than it would have. And everything else was negative. And he had a remarkable recovery. So completely cleared. And it was clearly that tubulovillous adenoma. So just a little review. So this was one of my colleagues up in at Mayo and Rochester Neurology, and their nice review in the Archives of Neurology, where you see the presence of antineuronal antibodies and clinical suspicion of malignancy was identified for PET CT of 56 patients. 59% were picked up by PET CT, and then biopsy and was sometimes you don't even biopsy them, but for confirmation was in 10 of those patients. So a little bit updates, I won't go through this, but really PET CT has, become, of course, now there's, limitations on how many PET CT scans you have because of the cost and expense with this and monitor, not only in diagnosis, but in monitoring follow-up. But this was the large report in JNCN that, 41,000 scans, it affected changes with initial staging and 35% restaging after treatment and 36% with changes, and recurrence after treatment in 29% of the patients. So, and here's just the breakdown: percent change of intended treatments, and you can see that, and the age-adjusted impact, which is significant. So I'll end just with a few, what's the future? Well, one of my colleagues, and I will pay homage to him, Dr. Ahlquist, died this last year of amyotrophic lateral sclerosis, but he was a wonderful colleague of mine for over 35 years up at Mayo Rochester, and he developed Cologuard, so with Exact Sciences. And then a couple of years ago in Precision Oncology, the Nature publication, his perspective, universal cancer screening, revolutionary, rational, and realizable. And it was that article in 2018, if you have a chance to read it, wonderful. And it was followed up by a couple of years later by Shrivastava and Hanish that were at the NCI, and MD Anderson, a very nice review in Cancer Cell on pan-cancer early detection, hyper-hope. And I think they gave a pretty good argument for hope. Here's one example that they referenced of the two was from the Hopkins group, of course, with Papadopoulos and Vogelstein and Kinsler and Lennon, first author. And I won't go into the details of this, but you can read it. It's a remarkable paper. And basically, here's what they were able to find. And this was basically with a variety of techniques that would be called liquid biopsies, if you will. But, here were cancers that were first detected by blood testing, and, particularly carcinoma, unknown primaries, and these are each individual ones. And then you look at this thing by this Detect A study that they ran, which I won't go into details, but the fact is that you could do that by proportion of cancers that are first detected by blood testing, first detected by standard of care, which you can see in the green. Breast arguably would be a large percentage, but you look at the small percentage or non-existence of standard screening care, and then of course first detected by various other means, and that included PET-CT, etc. And then with one of my colleagues up in Mayo Rochester and the group there, another large study that was of 6,600 participants, 2,482 cancers. This is their findings, which is remarkable. Detection increased with increasing staging, understandably, 30% for stage 1, 69% in stage 2, 83% in stage 3, and 92% in stage 4 malignancy. Arguably, in those later stages, you would hopefully have been able to find this with more traditional imaging studies. But in all cancer, sensitivity was 18% in stage 1 to essentially 93% in stage 4. And this procedure of tissue of origin, which was remarkable, was predicted in 96% of the samples with cancer-like signals of those. So the potential for this is remarkable, and it's, as I think we're all reading in the literature, it's really with many of the commercial approaches being taken out to determine what will be best. So I'll leave you with these quotable quotes, one of which is related to the past, present, and future by Albert Einstein. People like us who believe in physics know that the distinction between the past, present, and future is only a stubbornly persistent illusion. Physics always governs the way what happens, and arguably probably the biology too, but it gets a little more complicated, maybe arguably than physics even sometimes. And then this great quote by Emerson: all life is an experiment. The more experiments or observations you make, the better. So in summary, I hope you've appreciated that paraneoplastic syndromes are remarkable, and in your careers you will see them and hopefully be able to identify them and act early and hopefully help the patient. But they are significant, and it goes back and forth between neural and blood and skin, but skin is a big player, no doubt about it. Newer imaging studies, and then even more sensitive imaging and biomarkers probably will help us measurably when we suspicion this. Now, will this be part of just routine screening? So we won't even get to see, these paraneoplastic syndromes, or we may be seeing them at the very earliest. But obviously, as I told you, some of these go on for years before. There are two of those cases I showed you. So that, and then of course others that you recognize by the time you see them, unfortunately it's much more advanced stage cancer. So I thank you for your time, and hopefully we'll have a little time left for questions. Thanks very much.
Thank you so much. Amazing. We do have some chat questions. Bill asks, For immune-related paraneoplastic cutaneous eruptions, do you think this reflects effective immune response against the tumor? And how do you approach specific treatment of the skin symptoms? And does it influence whether the patient has already been treated with immunotherapy?
No, that's a great question because, the early on, it was like, well, the ones that are developing these immune reactions or, cutaneous reactions to ICI, are they the ones that were getting better? And there's certainly some data that says, and then there's other data that, as you recognize the immune system, you realize there are more players than whatever you're seeing that are obviously targeting the tumor with the therapy. And then it becomes sort of collateral damage with these. And so I think in some situations, if we can document that there's efficacy and that is associated clearly with some of the cutaneous reactions, it may just be that, as we're trying to understand what's in the tumor microenvironment versus what's out in our skin and, what is, of regulatory mechanisms as we deal with a lot of other diseases, cutaneous diseases, and understanding those pathogenic mechanisms versus things that may be used therapeutically to treat disease. I think we're in the same, balance right now where we clearly see efficacy, and how do you enhance the targeted treatment and, decrease or hopefully eliminate the off-target components of immunotherapy. And we're getting there. I mean, there's clearly some of the work now being done with, low dose, for a lot of GVH reactions and everything, a little sort of low dose IL-2 and a few other things to rev up your Tregs and things like this that may actually do much better than sort of the approaches we use with GVHD. But it's a great question and probably is going to guide us where we should be going with paraneoplastic syndromes.
Bill, did you want to try to ask your next question? I don't know if your internet's given out, maybe. All right, so his next question was, are there specific genetic mutations that have been found that underlie production of secreted ligands in which tumors, are basically mediating the development of the paraneoplastic syndrome?
That would be wonderful to know because, for example, there's not many, but that one case from Vanderbilt group, would have been wonderful to understand what was going awry with that melanoma that aberrantly was expressing such large levels of TGF alpha. And it's, there's some data out there about what typical half-lives are and, how that, but to be able to pick it up in the blood and urine, I mean, you had to have huge levels being secreted and by a little tumor nonetheless. So there, in that case, there must have been some, aberrant and the oddball, where we see, when you even look at a lot of typical tumors, you say, well, that's 8%, that's 12%, 15%, and then there's the 1% and 2% as you see them, and yet they're the most remarkable. My colleagues, college, we were looking at fusion, which was an uncommon event for Sézary syndrome, and it basically took the brake off because of the fusion protein with the ligand and the receptor that really drove the disease, arguably. But those are rare, so it's likely most melanomas we see that you never see this. So it tells you that probably the rare to ultra rare events.
So I have a follow-up question kind of related to that. I don't know if you saw the study from the Hopkins group. I think it was Anthony Rosen's lab that was basically postulating that at least a subset of scleroderma patients, it was arising because they had this tumor that expressed, I think it was an RNA polymerase mutation, and they developed an immune response against that to clear the tumor, and then it cross-reacted to self to generate autoimmunity. I mean, do you think that really be a common event and just many processes that we just don't have mapped yet? Or
right, well, yeah, or components of that. So which events that have to be all in place to see that. I mean, when you see, and if you've been in practice enough, you see these unfortunately paraneoplastic scleroderma cases where there's fairly rapid progression, and and yet if you look at all of scleroderma, you say, well, that's a small percentage. But those that develop these and identify, and then you can look at, and as you point out, that was a very nice presentation. They really could show each of those mechanisms that were playing a role in the ultimate manifestation. So again, you say, well, is that a rare percentage? Or, when you look at things, nothing is really common in paraneoplastic syndromes. But of those rare percentages that you see it, how consistent is that? Or is it some phenotypic copy of the real, typical disease? But you argue like, well, we don't understand the genetics of psoriasis very well, pretty well at least. And then you say, well, how is it that some tumor state and an immune response is mimicking that to say it looks psoriasiform or like psoriasis? And that of course is what's fascinating. When you really look at it closely, you say, well, this isn't psoriasis. This looks a lot like psoriasis, but it's clearly different.
Yeah, and I love that point. That's an excellent point. I think we had Jeanette Okoye making a very similar point when she talked about mycosis fungoides and how it can be a great mimicker. And so then it's like, what's
Right.
going on with that? So we have another chat question from Joachim. They asked, did you see acquired bullous epidermolysis as a PNS from a lung cancer?
Well, what kind of epidermolysis bullous? I mean, if it's typical EBA type, yeah, then that's well understood that those, and yet there's some that are not associated with any underlying malignancy, but those that we have had, and in fact, some that really point to it early, and then again trying to look at really what, and that's the nice thing that I was trying to point out with LeBaire, for example, where we focus in on particular antibodies that we and antigens, epitopes that we recognize as classic for that disease, and then sort of make the generalization that that's happening in a bunch of other these diseases, when in fact, if you really look at potentially other autoimmune responses that are part of that whole complex of autoimmune responses that you may find. I mean, we did that even for pemphigus with Dr. Grando, where, clearly desmoglein 1 and 3 are playing major roles, but then you start seeing all these other antibodies that, may be partly at play in mediating that otherwise classic pemphigus. So I think if you take that even for a disease as well understood as we understand pemphigus now, you could begin to just understand how complex it gets with paraneoplastic pemphigus or paraneoplastic EBA.
Thank you. Bill has another great follow-up question. What is your approach to the clinical workup of a patient that you suspect has a cutaneous paraneoplastic syndrome?
Well, that's a great question, because I can tell you, I'm having a patient referred in this week that I looked at him. I said, it didn't take me long. I said, I think you've got Bayes-X. And now I'm, going to have sort of a ENT eval, making sure everything's good there. But I'm trying to get him set up for PET CT, and trying to get him, and then of course I get the response back from the nuclear med people and say, well, you have to pick one of these. And do you think Bayes-X syndrome's on there? Absolutely not. So this is the difficulty. And then it's like, well, unless we get the right answer there, we're not going to, get them scheduled for that, because we're talking about not a cheap test, and that won't get covered otherwise. It has to be Medicare. So, this is the challenges with imaging. I mean, great technologies, but they're just in this day and age, there's certainly limitations on your, ability to attain those. But I would say we much earlier go to imaging studies like PET CT now.
Are there like specific red flags though? Like you're saying, it looks like psoriasis, but it's not exactly like psoriasis. Like, do you rely a lot on like the derm path evals, or like, are there just clinical signs that raise flags in your mind?
Yeah, no. Well, certainly when there's the psoriasis that, it's not going to behave well, and it may be going to erythroderma before you know it. And for whatever else was, triggering that. But clearly, yeah, I mean, we find these particularly as we're working with PRP these days. And now we're recognizing that based on some of the response to drugs, particularly with some of these IL-17 targeted drugs, there's some that respond great and there's some that don't. And then there's the other ones you say, just the other manifestations. It just, it's a good review of systems at that point. And as we see with our patients, some, really don't have a primary care provider. They like, well, no, I haven't seen a doctor in 20 years. And you say, and then you start asking about their screening. So I've had a lot of discussions with my colleague, Dr. Mangold, about this. But I think we really get pretty aggressive when we start seeing, and I wish I could tell you what that threshold is, but it's unfortunately it's one of these. It's sort of your sixth sense at that point, and realizing that it's just something's out of place that doesn't all fit together.
Yep. Clinical expertise. It's also a great point, I feel like, for all of our med student viewers to like just make sure you're doing the good review of systems.
Agreed.
Yeah.
Agreed. Yeah, that's very important. You have to be thorough, and there's some of the. By the same token, that as you get more experience, you just don't want to have anchoring bias with some of these, and then you just sort of say, well, it's a that,
Yeah.
and you say, well, it wasn't a that in this case.
Even in science, I feel like we can do that too.
Exactly. It goes back to what's good science.
Yeah.
You have to have enough skepticism.
Yep. Totally agree. Well, that was excellent. Thank you so much, Dr. Pittlekow.
A pleasure. Nice to be with you all today, and have a good day.
Yes, thank you. Thanks to all our viewers. We'll be posting this on YouTube after. So
Thanks,
everybody. Bye-bye.
Bye.